Welcome everyone. Just a short little webinar on how the NAT technique and the treatment of frozen shoulder might change the way that you treat in clinic. I think the last sort of 2 months I've been inundated with lots of conversations with therapists who are wanting to come and do the NAT workshop in Sydney in May. So I thought I'll make good use of my time and actually do a small webinar to give you a bit of an idea, and that way the general question hopefully will be answered if you watch this. So the NAT technique is designed, it's a manual therapy technique. It's based in its trigger point, so it's not, we're not reinventing the wheel by any stretch of the imagination. Simeon obviously had his own journey in regards to how he developed this technique, which is not unlike how I found Simeon and the like, and how the NAT technique has changed the way that I treat in clinic now. I'll be lucky if I dedicate two days a week to treatment of frozen shoulder, obviously with the NAT technique. I've never advertised it, primarily out of fear of being completely and utterly inundated with it, because as much as I enjoy working with the frozen shoulder, I do enjoy working with other areas and other dysfunctions as well. So with that in mind, for those of you who obviously have been struggling with working with the frozen shoulder, what you'll find is this technique, it's you're not going to end up getting a complete and utter change in just one treatment. It doesn't work that way. The idea is that this technique will work in a range of ways, and it will be over a period of time and a process as well. So each treatment you work on what progress you made from the last one. There's a series of steps involved in it, a sequence of treating certain trigger points in certain muscles, and the way that you do treat those is really important. And there's obviously a little bit of difference in terms of dealing with, whether or not there's traumatic frozen shoulder, which is more to do with obviously the byproduct of, say, nasty surgery or a really nasty subacromial bursitis, as opposed to one that's non-traumatic, where we don't really know the reason why. The etiology is still unknown. So the process of working through the NAT technique, it's a step-by-step process, and there's obviously different things happening at different phases of them as well. And depending on when your clients come in and see you as well, it will depend on, how effective you'll be, because the different phases, obviously, we're having different things happening at those stages. So keep in mind, the frozen shoulder is a highly debilitating condition, but also very, very treatable if done the right way. So frozen shoulder, as far as we're concerned, in Simeon's theories as well at the moment, which he's trying to go through in terms of his PhD, which will be fantastic to see it all unfold. We have an understanding that there is a real neurological component to frozen shoulder. I think that's the main thing, because a lot of people just feel it's a purely physiological, but I don't necessarily think that's the case. And it's all to do with, obviously, the agonist and antagonist relationships and how dysfunction changes the way that they behave. So one of the first things that we notice in frozen shoulder is that there's been a switching or a changing of these agonist and antagonist relationships, and we feel that happens from a neurological point of view. So the normal patterns are disturbed with a whole range of different types of dysfunctions, and basically what we're thinking and what we're feeling here is that there is a change to the balance of those muscles, and obviously we have compensatory changes made to these muscle groups. The brain is then, to some degree, asked to reorganise some of these movement patterns, and obviously that starts to change the intra and extra articulate structures, and that's obviously where we see the start of the frozen shoulder. So The body tries to adapt, but eventually it deteriorates. It doesn't, and then our range of movement and stability and pain kick in. So, and then what we start seeing is this what we feel is this neurological switching of muscle groups. Perfect example of that is the biceps with the teres minor, and obviously triceps with pec minor. But these aren't the basis of the treatment sequence. It's just that's the feeling we get. Chronic inflammation is a big part of the condition, there's no doubt about it. Four particular areas that we feel are highly effective with the frozen shoulder. First one at the top, no surprise, long-headed biceps. It's about every rotator cuff dysfunction I see, and on ultrasound there's always a certain amount of swelling around long-headed biceps, but finds its way beautifully into the joint because it inserts in there. To that subacromial space, which is the bursa. Long-headed triceps brings in that just at the back there, and obviously the posterior capsule as well. So what we're trying to do is we're looking to create, believe it or not, a localized acute inflammatory reaction to try and stimulate the body's own healing process, because hopefully that will help break the cycle, will trigger breaking the cycle of that chronic inflammation, and that's we definitely start to see from one treatment to the next. We use trigger point release, something new to the world of manual therapy, I would assume not. So once again, we're not trying to reinvent the wheel, guys. This is just about the sequence of treating it, really. And we tend to feel that certain trigger points are a lot more heavily associated with dysfunction than others. It's constant moderate pressure to deep pressure. Obviously, we're trying to work in and around those trigger points and trying to obliterate them. So the idea is that you're moving in and off them and around them in that zone of pain until you feel that it completely plateaus. You know, it doesn't sound like much, but it's a hell of a lot more difficult than it sounds like sometimes. So what we're trying to do is just really try to lessen all that hyperactivity and hypersensitivity as well, alter that local reflex arc, and hopefully we start to get some changes around the shoulder. And the first thing we try and knock off is night pain. That's the first thing. Once we work on that night pain, then we can start to work towards the range of movement stuff. 3 presentations for frozen shoulder that we believe. An anterior presentation, which is the long-headed biceps restriction. So we'll see that in extension and the external rotation. Second one is the posterior presentation, which is the long-headed triceps. So obviously we'll have restrictions in flexion. And then the lateral presentation, which I find is probably the more difficult of the 3 to deal with, and that's the subacromial restrictions and induction. We can have combinations. We most definitely need to rule out impingement, bursitis, tears, instability, because that will be an underlying, and definitely rule out any neck, thoracic, elbow pathologies as well, because it is not unusual that they coexist as well. So the technique, obviously you need to work out where it is, so we work out what sort of presentations, as you can see there. They're slightly different. Obviously the anterior is obviously a long-headed biceps type. Long head is grossly thickened, there'll be local tenderness, and obviously all the way up through that tendon itself, especially around that transverse ligament and down from there. The posterior, obviously, once again, that'll be more of a bulky mass at the rear of the glenohumeral, right where the long-headed triceps kicks in, and that can also bring in that characteristic of real restriction in flexion and so forth. And the lateral frozen shoulder, much harder to palpate. Usually the bulk of the inflammation is happening deep in the shoulder. So we look to about 2 centimetres below the tip of the acromion, and that's where we usually find that really hypersensitive area. So the anterior frozen shoulder tends to, like we said, begins with a bit of a biceps tendonitis, down the front of the shoulder and down the arm itself, catching pain. That's not unusual. I've found even with treatment for up to 50% of the biceps tendonitis can lead to frozen shoulder if mismanaged. So, you know, there's no doubt that the anterior is probably, for the most, probably accounts for about 70% of it. and it's also the easiest to treat. So if your client's coming in through, it's always nice to have one with an anterior frozen shoulder, trust me. Posterior, obviously we said it's a little bit different, triceps tendonitis almost. A lot less catchy pain. It's really more of a stiffness component. They make up about 20% of those cases, and believe it or not, they usually come in combination with the lateral. Responds well to treatment, but tends to require a deeper and a lot more vigorous approach. I can definitely count for that. I've got one at the moment who's very, very stubborn, and but you push through, and we're starting to get some changes now. Yeah, look, the lateral frozen shoulders, not the ideal one. Depending on when they come in, will depend on where you're at with them. They generally start with the catching pain in the shoulder. Obviously, the arm is most painful when it's elevated. They'll have that real painful arc. They do make up the most severe of the cases, and believe it or not, they are probably the result of potentially a nasty bit of surgery that went wrong, or the rehab, or a really, really nasty subacromial bursitis. Rarely see them presenting on their own. As we said, they usually present with an anterior or posterior, and once again, they account for about 10% of them as well. So the techniques itself involves 5 simple components. We call the 1, 2, 3. Other steps like the 4 and the 5, they're added in, but we form the basis of just 3 steps, and they form the basis of the technique, and then we add other techniques on depending on the cases and what's going on. So these procedures must be done in the right order, otherwise you're just playing around and probably won't get the changes that you need. Step 1 is basically just treatment along taut band up the arm, believe it or not, along almost the lateral part of the arm, the triceps move upwards and stretch the band, and obviously looking for any significant nodules along the way, and just working through those. So step 2, obviously they're sidelined for this treatment, believe it or not, for this step 1 and 2. Now we're obviously trying to locate pain basically in the teres minor, which is, can be a little bit tricky to find this one, but obviously once you've found it a couple of times, you find it. Once again, we're bringing the arm across the body while we're in sideline, and we'll be picking up that trigger point right at the back there. Sustained pressure again. You've got to ask your patients to breathe through it and so forth within your pain threshold, so it's really important. Step 3, we are literally, all we're doing here is involve taking the arm in with a bit of circumduction. We don't force it, we don't take it into the pain zone, we take it out. Just slow, confident moves. When you do that several times, we repeat this step over and over again. Now step 4, this is where we target the long head of biceps in particular. We've got to hold the trigger point sometimes for up to 3 minutes. I know that sounds absurd, but literally that's what it does. Do not come off it too early, because it tends to feel like the bicep spasm. So we work carefully, slowly, and trying to find all facets of that long head of biceps trigger point. Step 5 is where we're looking for the super hot trigger point, the infraspinatus, the one that feels like the front of the shoulder is about to blow out. So the pain will be really, really distinct through the front of the shoulder pain. And once again, we just wait for that to subside. So frequency and treatment of expenses. So if we're looking at phase 2, so basically we treat them once a week for 3 weeks, and then fortnightly for 3 sessions, and then monthly, or more often every 3 to 4 days if required. This should take about 3 sessions to lessen the inflammation, so hopefully get on top of the night pain. That's the first thing, and then obviously followed by 3 to 5 sessions to regain some range of movement. Now that varies from individual to individual. So, you're basically looking, you're looking at, in a weekly treatment, coming in to get on top of that night pain, and then depending on the first 2 or 3 treatments into the pain range of movement, you may be able to move them out fortnightly and so forth. And you're building from one to the other. You will sometimes not get those changes straight away because you're still learning the technique. So, you have to persevere and you'll slowly get better and better. What it does mean is that you'll be seeing your clients a fair bit. You need to explain that this is the treatment regime. You need to take the time to sit down with your clients and say, listen, this is not going to happen over one night. This is not going to happen over 2 treatments. It's not going to happen over 3 treatments. There's going to be a certain amount of treatments involved. I would allow yourself a good 45 minutes to start off with when you're first doing this, for sure. It'd be entirely up to you what you charge. But by the time you get 2 or 3, 4 clients in a week treating frozen shoulder, you can soon start to become inundated with frozen shoulders, which in one way is good because all of a sudden you're forced into learning it, which is basically what happened to me. But once you start getting really confident treating each one of those steps, you really do start to see the changes. You need to explain to them that obviously the night pain is the first thing that you're trying to get rid of, and that the range of movement will come from there on in. Phase 3, once a week. Once again, you're looking at for 3 to 5 sessions or more, depending on that. Depending on the client. Once again, you can go once a week, or if they're really bad, every 3 to 4 days. Nothing less than that, but it should take about 3 to 5 sessions. As a rule, 85% of the cases can be treated in less than 8 to 10 sessions. Okay. And then as a guide, your phase 1, you're looking once a week for 3 weeks, then fortnightly. This will then once every 3 weeks. Then you should take 3 to 5 sessions to listen to information, and as we've mentioned, followed on by 5 to 7 sessions to gain the range of movement. And that basically takes us to the expectations that you can see with your clients in regards to what sort of changes that you want to get. For myself, I've been really reluctant to advertise about treating frozen shoulder. It's been definitely all word of mouth, primarily because of being inundated with this. So much so that I'll be looking forward to a couple of therapists being trained in this technique in and around my area, and hopefully we'll start to see a bit of a spread of people in Sydney and definitely all around Melbourne, and the capital cities would be fantastic. And we can really build up a referral network, and then look at mentoring you guys through using this technique. But it will change the way that you do practice. There's no doubt about it. And if in terms of building a reputation for a certain niche or treatment of a certain dysfunction, this is certainly it. There's no doubt about it. Feel free to contact me if you need to in regards to anything about the frozen shoulder. But definitely looking forward to the workshop in May. It should be fantastic. Got really good numbers so far. So I hope you enjoyed the webinar. Hope it's answered some questions. I'm still more than happy to answer more questions if you want. I'm definitely not the type of person who's just say, no, that's it, don't ask me any more questions. But if you do, I'm easily contactable on Facebook, whatever the case, whatever mediums you feel, through the website itself or just through a email. All right, guys, enjoy your week. Happy trading, and we'll see you soon.